Hello, everyone, and thank you for joining the fourth and final session of the Journey of Healing training series titled Intersection of Medical Forensic Healthcare. My name is Aaliyah Smith-Gomez, and I am a project coordinator at the National Council of Urban Indian Health, also known as NCUIH. Joining me from our team are Maddie Curry, the Public Health Program Manager, Amy Lord, Senior Communications Associate, and we are honored to have you all here with us. We kindly ask that you place your name, organization, tribal affiliation, and job title in the chat box. In addition, we welcome any feedback you would like to provide about your webinar experience in our survey, which is posted in the chat box as well. Next slide, please. As we dive into our session, here are a few things to keep in mind. The session is being recorded. All mics have been muted unless otherwise directed. Questions can be typed into the chat box, and a Q&A will follow at the end of the session. Next slide, please. As shown on the agenda, our presenter will provide a detailed presentation on sexual assault prevention within the AIAN community. We will end the session with a Q&A, survey reminders, and upcoming opportunities at NCUIH. Next slide, please. To provide a little background on NCUIH, the National Council of Urban Indian Health is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V urban Indian organizations under the Indian Health Service and the Indian Healthcare Improvement Act. NCUIH strives to improve the health of over 70% of the AIAN population that lives in urban areas, supported by quality healthcare centers. Next slide, please. We also would like to take a moment to recognize that addressing sexual violence of Native communities is an incredibly sensitive topic that might affect some participants today more than others. If you find yourself impacted by today's discussion, please connect with your support network or reach out to NCUIH and we can provide you with the healing resources that you need. Next slide, please. We will now introduce our wonderful presenter for today. Nicole serves as the forensic nursing consultant with the IHS Division of Nursing Services. Prior to her work with IHS, she served as a forensic nursing specialist with the International Association of Forensic Nurses and was the clinical program manager for the District of Columbia Forensic Nurse Examiners. Stahlmann was an emergency department nurse and an adjunct instructor, teaching both undergraduate and master prepared students at Georgetown University. She continues to practice clinically, providing care for patients who have experienced violence. We will now turn it over to Nicole for her presentation. Thank you very much.
Thank you so much for that introduction. And just, can I get a head nod? Is my volume okay? Can you guys hear me all right?
It's good on my end.
Okay, perfect. All right, excellent. Thank you. Hello and welcome to the session today. I certainly appreciate you guys being here. So my name is Nicole Stahlmann, and I serve as the forensic nurse consultant with the Division of Nursing Services at IHS headquarters. I just wanted to say thank you really quick for NCUIH to recognize the sensitivity and the topic of discussion that we're going to have today. I think it's also important to recognize kind of the eyes and ears that live within our virtual space and then within our wherever we're working today or our homes today, just to be mindful of also their eyes and ears and maybe anything that they're listening to. So thank you for that. We can go into the next slide. And so on the slide, so there's a ton of information that will be packed throughout this webinar today. Some items are going to be more surface level just to raise awareness, certainly to support prevention efforts and then start this discussion. So it's saying that by the end of the session, you guys will be able to list general statistics related to victimization, describe the correlation between victimizations, understand IHS forensic healthcare historical information, describe the current state of IHS, and as that relates to medical forensic healthcare, and recognize IHS medical forensic best practices. So throughout the session, we will also have polling questions. There will be a Q&A portion if we have time for that, and then resources. So on this next slide, you'll see a diagram here, a pretty colorful diagram. So as a healthcare providers working in the forensic healthcare world, we walk this fine line of healthcare in the criminal justice system. And from a medical standpoint, the intersection is that we are offering that patient supportive healthcare, certainly offering resources and follow-up care to help stabilize and support that regaining of their spiritual health and well-being. So overall, our main focus is the patient, and we are here to provide healthcare. So as you can see on this diagram, medical forensic healthcare intersects with a number of different factors. So it can intersect, for example, with the patient as it relates to that violent crime, providing trauma-informed, patient-centered healthcare, conducting the medical forensic exam, offering medical interventions, for example, like STI treatment, collaborating with multidisciplinary teams, engaging with the criminal justice system, whether that's providing fact or expert witness testimony, or even supporting the patient through that system, applying prevention efforts, so maybe through awareness, outreach, or education, ensuring we are conducting safety screening, whether that be for domestic violence, intimate partner violence, or trafficking, and then certainly supporting the patient's needs to regain their health and their wellness, ensuring that patient, their families, and communities are safe prior to and following that traumatic event. So we're going to start with a polling question. Yep, perfect. So there are about 5 polling questions throughout the session today, and go ahead and select the best answer that you think reflects what's most accurate response here. So every blank second, an individual is sexually assaulted. Is it A? I guess you don't have an A. Is it every 68 seconds, every 93 seconds, every 120, or every 60 seconds? Go ahead and select your response. We'll give you a few more seconds on that. As you guys are answering, I will talk more about statistics in a few slides, but raising awareness creates for healthy discussion and prevention efforts. Perfect. So can we see those results? Awesome. We kind of have a variety of a few different answers here. We have 31% for 68 seconds, 31% for 93, 15 for 120 seconds, and 23 for 60. Perfect. I will share that answer in 2 slides. Let's go to our next polling question. What is the percent of American Indian Alaska Native women who have experienced violence in their lifetime? Is it 19.9%, 44.3%, 70.9%, or 84.3%? A few more seconds. Go ahead and select your response. Perfect. Let's see those answers. Perfect. We have 64% for 84.3, 29 for 70.9, and 7% for 44.3%. Awesome. Okay, so on this next slide, you're going to see here, based on our polling, right, per the Rape, Abuse, Incest National Network, or RAIN, every 68 seconds, an individual in America is sexually assaulted. That is just after every 1 minute. That is really sad and really unfortunate. And it's really unfortunate to share that statistic, but I feel like we have to have the discussion and raise this awareness. Over half of women and almost 1 in 3 men have experienced sexual violence involving physical contact during their lifetimes. 1 in 4 women and about 1 in 26 men have experienced completed or attempted rape. So following along from that second polling question, which a majority of you got correct, is that more than 4 in 5 American Indian Alaska Native women, or 84.3%, have experienced violence in their lifetime. And 56.1% accounts for those who have experienced sexual violence. I want to mention that statistics alone insufficiently reflect the disparities experienced by American Indian and Alaska Native individuals, and providing statistics almost creates this commonplace, this dismissive kind of tone, if you will, and it lacks the honor for each of these individuals representing these numbers. So I just wanted to put that out there, that it's important that we are aware of these statistics, but we also have to make sure that it doesn't create this commonplace in mentality. All right, so on this next slide, you'll see that American Indian Alaska Native women are 1.2 times as likely as non-Hispanic white-only women to experience violence in their lifetime, and 1.7 times as likely to have experienced violence in the past year. The 2015 US Transgender Survey reported that 47% of transgender people are sexually assaulted at some point in their lifetime. 65% of American Indian LGBTQ2+ community reported to most likely have been sexually assaulted in their lifetime. 40% of women involved in sex trafficking are identified as American Indian and Alaska Native. And homicide is the 3rd highest cause of death in girls aged 15 to 19 and women 20 to 24, estimating that American Indian Alaska Native women face murder rates more than 10 times the national average in some communities. So again, providing statistics alone does not capture the actual depth of individual and familial historical trauma and oppression, including violence experienced across the entire nation. It goes back to not wanting to create that commonplace mentality, but also making sure that we're honoring and respecting the individuals that represent these numbers. So on this slide, this next slide here. Perfect. So thousands of Indigenous women, girls, Two-Spirit individuals, and people have gone missing or have been murdered. And grassroots advocacy efforts have created national attention to this crisis of missing and murdered Indigenous people or persons, which is MMIP, also known as MMIW for women, or MMIR for relatives. And there are certainly other names specific to a particular tribal community. It just depends on that community and what they are, or what language they're using for this topic. So this crisis encompasses a wide scope of violent crimes, including that correlation between human trafficking, sexual violence, domestic violence, and intimate partner violence. The blue circle that you see on the screen, so that is represents SANE-A's Act. So this is a bill that directs the DOJ, or Department of Justice, to review, revise, and develop law enforcement and justice protocols to address MMIP. And this includes training, education, technical assistance, strategies for improvement, and then certainly improving the data that they're capturing, or then to help improve the response. To pay respect, it's also important to highlight that the act was named after Savannah LaFontaine Greywind, who was murdered in August of 2017. So that is where the SANE-A's Act is named after it came from. And for awareness, in that last circle on the right, the Not Invisible Act of 2019 is legislation aimed at addressing the crisis of missing, murdered, and trafficked Native people by engaging law enforcement, tribal leaders, federal partners, and service providers to support improving coordination across federal agencies. And just last year, NIAC published a report, and the report is called Not One More. It's a list of recommendations for federal agencies to help improve that response. And I'm going to post that PDF in the chat for you guys, while you guys answer our third polling question. So on the next slide, you'll see that polling question. Perfect. I'm just gonna copy and paste into the chat here so you guys have access to that report. Hopefully you see that. All right, so which of like A through D here, which answer best represents the definition for human trafficking? And I will tell you, when I was looking at this, it is really hard to read these responses only because they're so, it's just difficult to read because they're not accurate except for one of them. So is the correct response or best definition of human trafficking? Is it transporting by force, fraud, or coercion for sex and labor trafficking? Is it recruiting by force for sex or labor trafficking? Is it sex trafficking through obtaining, transporting, providing by force, fraud, or coercion? Or is it obtaining, recruiting, harboring, transporting, providing by force, fraud, or coercion for commercial sexual exploitation or forced labor? Yes, that was difficult to read, so please excuse me. All right, perfect. Can we see those responses? Excellent. We have 89% for the last response. Excellent. We can close that and go to the next slide. We'll go on to, perfect. So human trafficking can occur in any community and victims can be of any age, gender, race, or nationality. I will tell you that victimization does not discriminate. Human trafficking is different than smuggling, and it can occur in one's home, in one's community, and there doesn't have to be this level of transportation to another location to be titled as trafficking. And then I will share that Our Rescue, it's ourrescue.org. They recently reported that 50% of trafficking cases, they stem from within the family. So 50% within the family. The Department of Justice, they describe human trafficking as the use of force, fraud, or coercion for a person to provide labor or services, also known as labor trafficking, or to engage in commercial sex acts, also known as sex trafficking. So perfect. Of the 80+% of you that got it right, the answer was D. And then on this next slide, you'll see here, it further describes that definition. And this is the Trafficking Victims Protection Act of 2000. And this framework outlines the action, the means, and purpose, or also known as the AMP framework, defining trafficking as an action of obtaining, recruiting, harboring, transporting, providing by means of force, fraud, or coercion for the purpose of commercial sexual exploitation or forced labor. So having that ingrained in my head, that was why it was difficult to certainly share that response in reading that last polling question for you guys. It's also important to highlight here, you'll see in the middle in the green box that minors induced into commercial sex are victims regardless, and that's regardless of any means. On the next slide, you'll see that this is the SOAR trauma-informed framework. So SOAR is a mnemonic device. It was designed by the National Human Trafficking Training and Technical Assistance Center, or NITAC, to help healthcare professionals with human trafficking that response and to provide a trauma-informed, patient-centered approach to their care. So they have hours of education on their website, but the very, like one slide, few sentences here, overview is that STOP. So the S stands for stop, to become familiar with the nature and types of human trafficking. O is for observe. It's to understand verbal and nonverbal indicators, including environmental factors. The A is for ask, and this is to engage with and screen an individual using a trauma-informed approach. And R is respond, and that is to respond to human trafficking. So identify patients' needs and secure culturally sensitive, available resources to provide them support. There is a hyperlink on that slide. You can certainly go to their website and you can take any of their courses or training that they offer. They do have a SOAR for Native Communities online module, and this is for providers or professionals serving Indigenous communities to help understand the issues surrounding human trafficking and its impact on Indigenous communities. So I encourage you, if you haven't taken that training yet, to take a look into it. On this next slide, you'll see here the correlation of MMIP and human trafficking. So for awareness, there is a strong correlation between the two, between MMIP and human trafficking. And human trafficking, it is the root cause of it. So truly there's a strong correlation between all victimization types, right? Whether that's sexual assault, domestic or intimate partner violence, trafficking, you name it, or even stalking. So stalking is something that is not taken as seriously as it should. And it's certainly not talked about enough. So it's something that maybe we should raise awareness on and have further discussion, because there's certainly a correlation there. So consider the correlation of a patient who presents, and this is from a provider's like mentality, right? Who presents with and screens positive for potential food, money, maybe medication insecurity, maybe unstable housing or being unhoused, maybe substance use or misuse and related vulnerability, mental health instability and related vulnerability, lack of culturally sensitive support, safety, and resources. So you have to immediately think that there's a potential for human trafficking. So first, I'm going to be in my head thinking, how can I best support this person based on their needs, based on their consent? But then the second piece to that is, what resources do I have available to help offer and support this patient? Not everybody that comes in with maybe food, money, or medication insecurity are going to, be flagged as potential human trafficking patients, but it is something that we have to question and then screen. Okay, on this next slide, similar to this last slide that we just talked about, that correlation, these are populations that are at greater risk and have a higher vulnerability to potentially being trafficked. So those include, like we mentioned, houseless or unhoused, identify as LGBTQ2+, maybe have substance use, people of color, immigrants, co-occurring disorders, maybe disconnected youth, people with disabilities. Maybe there's a lack of education or proper school system for them. Maybe there's food and medicine insecurities, like mentioned previously. So that list has been known to have that population at greater risk for potential vulnerability to human trafficking. So on this next slide, these are indicators of human trafficking, also known as red flags, that providers, that service providers are trained to be on the lookout for. And this includes physical, psychological, and environmental factors. And there's a whole list here. So physical and or sexual abuse, pattern injuries. So pattern injuries, this is something that you can link a tool or object to. So it created the injury. So this would be, for example, like a belt or ligature. Pattern of injuries is very different than pattern injuries. So pattern of injuries is multiple injuries in various stages of healing that occurred at different times. You'll see potential bruising, discoloration, abrasions, which are more superficial, lacerations are deeper. You'll probably see maybe tissue bridging with it, but sometimes lacerations need a repair with sutures, if you will. There's potential pain and tenderness, multiple STIs or sexually transmitted infections, multiple pregnancies, malnourishment, maybe there's tattoos or branding. There could be a level of guilt, shame, or embarrassment, or even there could be, I'm all alone, or maybe there's distrust with the system. There could be depression and regret. They could dissociate. There could be a level of paranoia. There could be suicidal or homicidal ideations. They could lack, there's a lack of seeking healthcare, or even on the other side of that, maybe it's the overuse of healthcare. And then their current living situation, maybe they live in an overcrowded place. Other common risk factors for Native American communities can include individual, relationship, community, societal, or historical factors. And this could be, for example, like maybe there's dysfunction in the home, or they lack role models, or there's an influence of drugs or alcohol, or even gangs in the area or home. There's a lack of prevention efforts. Maybe there's a lack of solid reentry, like support system. There's racism, historical trauma, oppression, that list goes on. And then certainly something not listed here is that the patient, they might not present with a single red flag. They might not have a single red flag that they're presenting with, but every single patient and victim of trafficking, they present entirely different from the next. So as providers, as individuals in this field, we have to ask these questions, and we have to be able to screen our patients, offer them support, and offer them effective resources. So on this next slide, you'll see here some health consequences related to sex trafficking. And that includes being victims of rape, unwanted pregnancy, contracting STIs, being physically assaulted, dissociating, experiencing traumatic brain injuries, and becoming victims of homicide. Again, making note of that strong correlation back to MMIP. Patients might seek healthcare for a variety of reasons, right? Maybe they're coming in for abdominal pain, pelvic, maybe genital pain, lumps, bumps, bruises, you name it. Nurses are a trusted profession, and because of that, it's important that we're asking our patients these safety screening questions to ensure that we are capturing the most appropriate diagnosis for them, and that includes for trafficking. All right, so on this slide, we're going to jump into kind of transition into programmatic related information, some general strength-based resources and information, if you will. All right, so on this next slide, you'll see this kind of provides an overview of the foundation for forensic healthcare within IHS. And it's important to give respect to that foundation because it really set us up for success and kind of where we are today. So the IHS Forensic Healthcare Training Program was established in 2011, and that was to train healthcare providers to treat and provide medical forensic healthcare for injuries sustained from violent crimes. Through a contract with the International Association of Forensic Nurses, IHS delivered training to healthcare providers to acquire and maintain the knowledge, skills, and that competent clinical forensic practice to improve the response to sexual assault, intimate partner violence, child abuse across IHS hospitals, clinics, and health stations. So that contract lapsed in 2020, just like a number of things in 2020. A lot of things happened then, right? But certainly COVID, staff turnover, among other things, is a reason why that contract lapsed. So on this next slide, we're going to talk about medical forensic healthcare. And on a positive note, since that contract has lapsed, we have been able to reinstate a new one, among other programs. So on this next slide, so there are about 35 IHS tribal and/or urban Indian organizations, so ITUs, that make up hospital service units and facilities that are currently offering medical forensic services. So right now, 35 programs. If services are not available, patients are appropriately transferred to the nearest facility for medical forensic healthcare. And all healthcare providers, all ITU healthcare providers are offered resources, even continuous training to provide minimal care in the event that services are not available. So on the next slide, you'll see, so these are the current forensic healthcare programs that we're offering. And I'm going to talk about the Division of Behavioral Health, who manages the Domestic Violence Prevention Program. And then within the Division of Nursing Services, where my position sits, I manage the Forensic Healthcare Funding Opportunity, as well as the Forensic Nursing Consultation Program contract. So on the next slide, we'll start with DBH, Division of Behavioral Health. So they maintain and manage, again, the Domestic Violence Prevention Program, or DVP program. They have about, they have a total of 41 grants, not about, excuse me. So they have 41 grants that have been and will continue to be funded through 2027. And with the DVP program, there are 37 grant awards totaling 7.4 million annually. And with Forensic Healthcare Program, there are 4 grant awards for a total of 1 million annually. On the next slide, this is just to highlight some of their program activities. So through this program, Some of the programs are focusing on prevention efforts that address domestic and sexual violence. Some are establishing advocacy, case management, crisis intervention, whether that's through education, training, or technical assistance. And it's important to say that this is meeting the needs of their awardees' communities. So anything that meets their needs and what their focus is, and how they're focused, how they're best supporting their patients and communities. Some programs are establishing forensic healthcare related services. Each one is unique, but there are a ton of great efforts that are being established through these DVP program funds. On the next slide, so this is the forensic healthcare funding opportunity. So through the Division of Nursing Services and federal set-aside funds, we have awarded 6 total awards in March of 2023. The goal has been to support the building or expansion of forensic healthcare programs, which has helped boost or create additional resources, such as medical forensic examinations for patients following violent crimes. This funding also allows for training and education for healthcare providers, ensuring that program sustainability and retention of staff. So on the slide, it says 16 awarded. We have sent out 6 total awards because we have the Billings area. So they submitted for the application and they are serving 7 of their federally operated sites. The Great Plains area, they're serving 5 of their federally operated sites. We have the Chinle Service Unit, Lawton Indian Hospital, Northern Navajo Medical Center, and White River Service Unit that are providing these services through these awards, through that funding opportunity. Excuse me. On this next slide, you'll see the contract. So kind of mentioned, so the IAFN, International Association of Forensic Nurses, they had the contract through 2020, but it's since lapsed. But this is now where we are as far as reinstating this contract. So this is the Forensic Nursing Consultation Program contract. The contract was awarded to Texas A&M University Center of Excellence in Forensic Nursing, and they are providing training, education, and technical assistance for healthcare providers to become trained as sexual assault nurse examiners, sexual assault examiners, forensic nurse examiners for our ITU programs. The contract will also support program development as well as mentorship opportunities, enhancing forensic nurses in the field. I should say forensic healthcare across the field because we also have providers, not just nurses, that are becoming trained. And I'm going to take a drink of water really quick, so please excuse me. Hopefully that helps. Forgive me. All right, so we're going to jump into best practices. And even on the next slide here, from a medical forensic standpoint within Indian Health Service, violence is a healthcare issue. So being a healthcare issue, it is about providing that holistic approach to preserving the life of our patients. Sorry. It's about providing the patient with trauma-informed healthcare that they need to rebuild and regain their life to a normal state. And that's following a traumatic event, right? Also, when I say normal, normal as in the patient's normal, because everybody is unique and their normal is nobody else's. On this next slide, you'll see here that IHS strives to ensure best practices are followed by healthcare providers as it relates to forensic healthcare and best practices that meet the needs of our patients. So with saying that, each exam is tailored to the specific circumstance and the patient assists in making decisions, and they are the ones who are ultimately in control of the examination. So our providers have access to the Indian Health Manual, so Part 3, that includes Chapter 29 and Chapter 31, both sexual assault and intimate partner violence. They have access to the National Protocol for Sexual Assault Medical Forensic Exams, both the adult, adolescent, as well as pediatric protocols. New to the forensic nursing world is the National Protocol for Intimate Partner Violence, and that includes the medical forensic examinations. So that's a new protocol. They have access to national best practices for sexual assault kits, a multidisciplinary approach. Their scope and standards of forensic nursing practice. Certainly any kind of training, education, or technical assistance that they need, I'm happy to help with, as well as additional resources. We have guidebooks that are available. I'll talk about at the end of the presentation today. Webinars, toolkits, certainly sit on committees, etc. All right, so on the next slide. Perfect. So as a best practice, the IHS emphasizes the importance of a trauma-informed approach, which considers the impact of trauma and patient safety. The framework is not a one-size-fits-all. Rather, the use of trauma-informed approaches that places emphasis on each of the following bullets there. So appropriately screening for intimate partner violence, domestic violence, sexual assault and abuse, even trafficking, attending to the patient's emotional safety as well as their physical safety, strengthening patients' capacity to recover from the traumatic effects of abuse and violence by providing information, resources, services, and support, and educating patients, service providers, and the community about the impact of trauma on the patient's health and well-being. Again, going back to that raising awareness and supporting prevention efforts. Excuse me, I don't know what's going on with me. I'm sorry. So on the bottom of the screen, you're going to see a bunch of colorful bubbles. So these capture the various trauma-informed principles outlined by SAMHSA. Sorry. So SAMHSA is the Substance Abuse and Mental Health Services Administration, and those bubbles, so they include a realm of safety, trustworthiness and transparency, peer support and collaboration, empowerment and choice, and cultural, historical, and gender issues. So not only our medical providers, right, but all individuals that connect with our patients, such as advocacy, law enforcement, prosecution, anybody else that works in the facility, they should all be providing to a trauma-informed approach. On this next slide, so if programs are offering forensic healthcare related services, they will formulate a care plan that includes a medical forensic examination. The patient assists in making that decision if they want the exam or not, and they are in control of the examination. The medical forensic exam can average anywhere from 2 to 4, maybe 6 hours, just depending on that situation. But it can include obtaining that patient's consent to conduct the exam. This is both written as well as verbal consent, and that is fluid throughout the exam. Gathering a medical forensic history. So this includes a past medical history, surgical, social history, and the patient narrative of what happened during the assault. And that narrative helps us guide the medical forensic exam. Conducting a safety screening and a safety screening assessment for domestic violence, intimate partner violence, trafficking. And this is based on validated evidence-based screening tools. Conducting a physical assessment, so a head-to-toe exam or potentially focused, given that patient's narrative or their request, right? This also includes a component of documentation and capturing photographs of any kind of findings. There's a component of a detailed anogenital exam, and that's with the use of a speculum to visualize the vagina for any potential injuries or findings. There's a component of collection of forensic evidence using that evidence collection kit. We have treatment options, so medications, for example, for STIs or sexually transmitted infections, emergency birth control, HIV prophylaxis, hepatitis B immunization, tetanus immunization, etc. Collaboration of resources and appropriate referrals, including follow-up with, for example, behavioral and mental health services, advocacy services, again, coordination with the criminal justice system, if they're not already involved. And then, of course, discharge, teaching, and safety planning. So the box on the right of the screen, this includes the exam purpose within IHS. So the exam purpose is to provide a safe environment for possible disclosure. And when I say that, please know that this is not the main goal of that exam. Another purpose is to obtain and offer medical care. The third bullet there is to educate about the health effects of intimate partner violence, domestic violence, sexual assault, and other victimizations, and then offer resources, referral, and safety planning. All right, so on this next screen is another polling question. So true or false, as healthcare providers, we do not screen the patient and we let the patient self-identify as being trafficked. So is that true or false? Maybe a trick question there. Perfect. We can see the responses. 89% of you said false, and that is correct. We, as healthcare providers, we must screen our patients and not let or have to let that patient self-identify. I will tell you that some patients do, but it's our role as healthcare providers to make sure that we're screening them accordingly. So kudos, awesome job on that polling question. All right, so we're going to jump into this slide here. So before understanding safety screening questions and why they're being asked, we have to understand why screening our patients is important. We can't just kind of sit back and let our patients or hope that our patients self-identify. So screening our patients helps to identify patient health risk, which may not be physically evident or reported during routine healthcare visits. Patient health risk information can be used to address identified needs and implement prevention services to decrease further patient risks. And it allows for the opportunity to properly treat and diagnose our patients. So if we are not screening 100% of our patients, we are not capturing that true and proper screening. So we are then missing that opportunity to properly diagnose, treat, and offer quality resources for our patients if we are not screening them accordingly. So there are a bunch of questions on this slide that you're seeing here, but these questions were pulled from the Adult Human Trafficking Screening Tool and Guide, and that's through ACF and NITAC. What's most important to note is that the provider is assessing the risk of current threat and harm, ongoing threat and harm, and supporting the individual responses in a trauma-informed approach, and then offering culturally appropriate resources. So the safety screening questions can be answered yes, no, maybe the patient is declining, or the patient can be unsure of the response. But the key here is that it's the patient that's answering. It's not the provider's decision. It's not the family's decision. It's not anybody that's accompanying them. It's the patient that's answering these questions. And more than one yes response should populate resources for this individual. Another key or important factor here is that I'm not just going through this checking boxes. I'm having the conversation with the patient in a trauma-informed, patient-centered like framework, if you will. Maybe some of the open-ended questions or screening questions that you want to have to kind of build off that screen or build off to have this conversation. Maybe start with, what are your health concerns at this time? At some point, you're going to ask, do you feel safe and well cared for? And can you tell me more about that? Is there anything that you're most worried about? Maybe another question is, can you share about your current living situation or tell me more about where you're living? Maybe another example is, earlier you mentioned that you did not have your license. Can you share more or tell me more about where your license is located? So that's going to bring more conversation than asking yes or no questions. It should be about the conversation. All right, so on this next slide, we're going to slightly pivot into the MDT, or multidisciplinary approach. And this includes the sexual assault response team, or SART, the MDT, the multidisciplinary team, and the CCRT, or coordinated community response team. So teams across our ITU sites work collaboratively and throughout the response. They build policies and procedures around their response. They identify everyone's roles and responsibilities. They draw that professional connection. They support prevention efforts and support patients, families, and communities impacted by violence in that trauma-informed approach. So you can see a list here of individuals that you want to have at your table for your MDT. You'll see that we have our ITU medical forensic examiners. We have behavioral health social workers, advocacy, whether that's community or systems-based. We have law enforcement. You'll see local, tribal, state, FBI, BIA, maybe others. Prosecution, a crime lab. You'll see adult protective services as well as child protective services. You'll have local, state, and tribal representatives and others. If you have somebody else at your table, that's awesome. I think the more the merrier, to certainly help build that response. So on this next slide, you'll see a question here. How does IHS define medical forensic healthcare program success? So this is done by providing prevention strategies and techniques, quality medical forensic healthcare, following best practices, information for the patient to make the best and safest decisions for their current situation, by providing community resources, and by providing supportive follow-up care and referrals. On this next slide, you'll see here a prevention framework, and there are a ton of different definitions out there, concepts about which activities are truly considered prevention and related efforts against violence. Understanding prevention is key, and awareness is prevention. So the most common definitions related to prevention efforts include here primary, secondary, and tertiary prevention. So primary prevention is acting prior to and preventing violence from happening. So this includes, for example, building champions, building the community, raising up culture in one's language, offering education, discussing healthy relationships and boundaries, being that ally, empowering and supporting all individuals. Secondary is intervening right after the violent crime has occurred and preventing it from happening again. So this includes offering that medical forensic examination. Maybe there's a component of education, outreach, or awareness. Maybe ensuring that the MDT is practicing to a trauma-informed approach in related efforts. Forever believing your patients, never questioning them. And then tertiary prevention is the quality review and efforts that over time help to change conditions and address long-term consequences. So this, for example, would be supporting individuals across the lifespan, those with adverse childhood experiences, maybe identifying and supporting, mitigating intergenerational and historical trauma. On this next slide, so here are a few preventative and supportive action items that can help create awareness and drive support for your patients, families, and communities impacted by violence. A number of bullets here, right? So to engage and raise in a healthy conversation within the community about violence. This includes having the conversation about sexual assault, sexual abuse, and trafficking. Ensure supportive and culturally appropriate resources are available and well known to the community. And this includes healthcare, shelters, mental health resources, spiritual health services, tribal coalitions, etc. So many opportunities and resources that are out there. Incorporate local culturally specific advocacy agencies and MDTs into practice. This includes for preventative and educational measures, for all victimizations. Allow for growth and development of provider education and related training as it relates to victimization. So this would be, for example, obtaining forensic healthcare training, maybe obtain human trafficking training, understand domestic and intimate partner violence, etc. Raise individuals up and engage in traditional ceremonies, model traditional behavior, engage in language and community, and support healthy reentry. And then certainly embrace those with welcoming arms. And then lastly, build your champions and allies within that community. Your champions and allies, they don't have to be within the healthcare system. They don't have to be within part of the MDT. Maybe it's our aunts, our mothers, maybe it's our fathers, that's something that we're building those champions and allies to support that community and prevent violence. On this next slide, so these are preventative action items continued here. Meaningfully incorporate the patient, respecting their decisions and supporting them with their needs. Support Native culture and language learners, especially in early childhood programs at K through 12 schools. Expand primary and secondary education to include Native people's history and cultures. Expand after-school programming for Native children and youth. Expand opportunities for higher education for Native students. And then certainly strengthen food security and security networks across the lifespan. You've probably heard me say this a time or two before, but culture is prevention. And there are a number of other supportive action items out there, but what's most important is that we are raising awareness, creating prevention efforts, in building and fostering a trauma-informed patient-centered approach for our communities. All right, so here's our last polling question. All right, so the question is, which of the following are helpful prevention techniques to help reduce sexual assault in Indian country? And that's all victimizations, I should say, in Indian country. I just went through a number of bullet points there for prevention efforts. Maybe give you a hint to select the last response. Because it is all of the above plus others. There are so many prevention techniques out there that I have not even covered. But it's important that we have this awareness that there are prevention techniques out there. Perfect. Do you want to pull up the responses? Oh, maybe. Did we? Oh, okay, so perfect. We have 100%. You picked all of the above plus others. Strong work. Thank you for doing that. Okay, on this next slide, kind of mentioned previously, were the guidebooks. And so the purpose of these guidebooks is to enhance care delivery for Native patients, families, and communities affected by violence by providing resources and support to forensic healthcare providers serving across the ITU settings. The first guidebook you see there on the left, so that's more inclusive of what is a forensic nurse or a forensic provider? What is a forensic examination? What is historical trauma? Other items within that guidebook include, for example, program readiness, program development and operations. There's information about MDTs on there. There are a number of hyperlinked resources. So for example, you'll see in there intimate partner violence and domestic violence screening tools that are validated and evidence-based. And you can certainly download a copy of this by going to our IHS.gov website. You can search it under forensic healthcare. The second guidebook there, this is covering medical forensic examination and exam considerations. So this would be, for example, child abuse and maltreatment, elder abuse. There's a topic about patients with disabilities, a number of pages on human trafficking and MMIP. There's special considerations for that exam. So for example, there's information about photography, evidence collection, there's chain of custody in there. Again, each of those are available to you for download at our IHS.gov website. On this next slide, so as mentioned previously, the Forensic Nursing Consultation Program contract, this was awarded to Texas A&M Center of Excellence in Forensic Nursing. So this is the contract that was awarded in 2023 and it will ensure that healthcare providers receive that specialized education and training to care for patients who've experienced violent crimes. And this is across the lifespan. So the contract is offering a number of CEs and CMEs. I couldn't tell you how many. One adult adolescent SANE training course is 40 plus CEs or CMEs. And the pediatric course is 40 plus on its own as well. Every month we have webinars. So we're offering 1.5 to 2 CEs, CMEs for those webinars. We have mentorship opportunities. There's a bunch of training that's available. If you are interested, or if you are an ITU provider and you are interested in taking this course, you can certainly email me directly, or a link to their courses can be found on that slide. So forensicnursing.tamu.edu. That's where you're going to find information about their training. All right, so we're going to go through, we're going to skip the next slide here. So this is Q&A. We'll go into resources. The next slide is another resource slide. And then I'm going to go into this thank you slide. And I just wanted to say, here's my contact information. So nicole.stahlmann@ihs.gov. So please feel free to reach out anytime. You'll also see on this slide the listserv, and you can certainly join this listserv if you're interested. So definitely share a bunch of educational opportunities, maybe funding opportunities, general information, educational opportunities. That is all shared through this listserv. So feel free to sign up if you're interested. And then I wanted to end the session with sharing this fabulous picture of a few of our forensic nurses. They bring so much light to certainly some heavy conversations and challenging work, right? So I'm just thankful for them and the work that they do. But it's also, it serves as a good reminder for us to ensure that we are providing or practicing self-care. So I encourage you guys to take the time today after this heavy conversation that we had, that maybe you guys are practicing in some self-care activities. I know we have like a minute left. I was trying to speak a little faster than usual, but if you have any questions, you can certainly email me. I'm not sure if we have time for 1 or 2 questions. I don't know, but yeah. If you guys have questions, you can put them in the chat.
Feel free to throw them in the chat and we will try our best to answer them. But thank you so much, Nicole, for providing that amazing presentation and this important information on this topic. It's a lot of good stuff. We will send everybody a copy of the PowerPoint after, so they can have access to those links. But we really appreciate your time and effort and that wonderful presentation you gave. And thank you so much, everyone, for joining us for this important NMIP prevention session. We appreciate any feedback you would like to provide about your experience today. Please complete our session survey by using your phone to scan the QR code on the slide or by clicking the link that will be placed in the chat. If you have any questions, please contact Maddie Curry, whose email will be placed in the chat, or Nicole Stahlmann. So this is our upcoming events. These are just a few other events that NCUIH will be hosting in July. So we have a number of events throughout the month. So feel free to join. And we also have our QR link and website here if you would like to check out more events that we will be hosting. Next slide, please. And as a reminder, the Technical Assistance and Research Center provides individualized technical assistance, training, and support to member UIOs. Next slide, please. And again, thank you so much for joining this important session, and any feedback you would like to provide about your webinar experience, please do not hesitate to complete our session survey. And thank you again for attending, and I hope everyone has a wonderful day.